Starting off knee demo in a prone position. Posterior point, we're going to be able to treat a little bit within the glutes, the hamstrings. Let's start with just a little bit of rocking, shaking, obviously introducing our client to the therapist touch, with the added benefit of providing a chance to do some compression so that we can see what areas we need to work on. So even just doing a little bit of rocking and shaking, I can feel that the hip moves okay. It's quite stiff in the lower back. It would likely indicate some tight hip flexors. The knee moves fairly well distal from the tibiofemoral joint, but definitely feels rather bulky. And I can feel some adhesions within the adductors on the medial side with my fingers and the IT band with my thumbs. Pretty standard drape. I'll just kind of pull it up above the knee. Bring my hand underneath the knee to support it, lift that leg up, and then go straight up at a 45-degree angle. It's a decent exposure here. Just a little bit below I guess I'm just a little bit above the gluteal cleft here. Do some fascial assessment. The fascia is good. This client has had very loose fascia since having 2 kids. Seems like she just kind of kept that extensibility, which is kind of cool. And a little bit going up the posterior knee. I'm gonna do a quick camera check. Yeah, we should be able to see pretty decently what I'm doing. So let's do a little cross hand stretch. Just across the popliteal space, I can feel a fair amount of tension, a fair amount of tone with the lateral gastric heads. Noting a bit of a valgus orientation to the knees. Perhaps a little bit of overdevelopment within the adductors. Do a little bit of muscle separation on the gastrics. I know that's not a module 2, that's a module 2 thing, not module 3, but that's where it's calling, where my hands are calling me. Severe arthritic changes within the knee often cause a fair amount of tension, a lot of taut tissue in and behind this, within the popliteal fossa. I actually feel a pretty tight popliteus here too, even just as I'm strumming across it. Does that feel okay?
Mm-hmm.
Cool. So, I'm just gonna use cross thumbs. A little bit of opening up the fascia back there. Being that the popliteus is the key that unlocks the knee, it takes it into that, takes it out of that that close pack position. I'm going to first initiate the knee flexion. So, folks who have severe arthritic changes or degeneration within the tibiofemoral joint, could be from meniscal tears, could be from a blown knee. It's often an area that needs some work. I think athletes could use it too. Before I apply some lotion, I just want to try and do a little bit of compression within that muscle. I'm just kind of strumming it back and forth right now. So going from that lateral femoral condyle to the proximal posterior surface of that tibia. And a little bit of transverse friction there. Thumb is an odd choice, but that's what I'm going with. Okay. We'll do a little bit of compression. I'm just going to bring my client's knee into a little bit more of a flexed position just so I can sink in there a little bit more. So basically just using thumb pad, nice and stacked, lines up with my wrist, lines up with my elbow. Not applying a ton of pressure. We feel a pulse, so we're just going to back off and we're going to reposition. Just going to take it through a little bit of this passive engagement here. Still doing okay?
Mm-hmm.
Excellent. Give that a little bit of a flush once I apply some lotion. Get a nice big grasp of the adductor muscles here. And a little bit of a SIBO action. We're experiencing some imbalances within the hips. Let's say a bit more of a significant valgus orientation. Maybe a misalignment of some of the innominate bones, which is coming a lot more in depth once we get into module 8. The adductor muscles tend to be quite hypertonic. Inadequate warm-up or running mechanics kind of make it feel like it has a lot of adhesions. It'll just be like a big set of real taut musculature that'll be on the inner thigh. A lot of the times what's going to happen too is going to be that you'll see the sort of a teardrop shape. You'll just see like a big tight muscle in and across here with adductor magnus. I actually feel that a little bit in with some of the medial hamstring muscles as well. So we're going to try and do a little bit of muscle separation. So we're just going to try and peel the hamstrings a little bit off of each other with the posterior thigh. I actually feel some adhesions breaking in through here. So now that I feel my adhesions, I'll do a little bit of cross fiber work. Not a ton of pressure. The adhesions I'm feeling are rather superficial, and this isn't a deep chronic injury. So I don't need to go too ham with it. Definitely feeling a lot more ropey as I go down. So I'm going to increase my pressure. Kind of using side by side hands here, but maybe a little bit better practice would be stacking one hand on top of another. A little more cross fiber friction. Try to break down some of the adhesions. Going towards that pes anserine tendon. And while we're on the tendon itself, why not do a little bit? So get a little bit of gracilis into here. Okay, something we can do to help expose the adductor muscles a little bit more here. We got this piece of the drape over here, yes? Just grab it by the knee here. I'm just gonna bring my client's leg in a little bit into abduction while pulling this drape here, keeping it nice and secure. You can see I can pull this client's tissue up quite a bit here. This drape, keeping it nice and covered. Grab a little bit of lotion. I'm also keeping my client's leg braced a little bit here. Hamstring muscles. Started off with a little bit of fascial work, and we did a teeny tiny bit of targeted therapeutic work that would be beneficial when we're not having to contend with having lotion in our hands. But now that we're working a little bit more grander scale here, we'll start with our Swedish techniques. So just some nice easy friction, some petrissage. As the lotion works more and more into the skin, I'll be able to pick up more and more of the musculature on the posterior thigh. Switch up your techniques a little bit. Give it a nice flow. It feels nice and relaxing for the client. It might even end up being a good neuroplasticity thing for us. Who knows? Grab a little bit more lotion. We can do some stripping with the knuckles, so nice and broad. Just coming up from distal, going to proximal. Is pressure okay? A little bit of a twitch there. You can always use finger pads as well. If you find that your finger pads are a little bit unsupported in a flat sense here, try butting them up a little bit, and then bring your other hand up over top. So differences between the hand setups, as you can see, when I'm going knuckles, I got about that wide of a surface area that I'm using. Once I get a little bit more to finger pads, then I'm kind of narrowing my focus down a little bit more. So you almost think about transitioning from effleurage, petrissage, and then moving into stripping, but rather than moving directly into stripping, we need to know a little bit more about where we should focus some of our attention. So it's almost like transitioning the intent from effleurage to stripping. It's really easy to switch back and forth, which is pretty handy when you're working on larger areas like this. I'll even do sometimes here, is because moving into the adductor area tends to be a little bit more of a sensitive spot, right? So sometimes what I'll do is I'll switch my hand placement and I'll start going back down this way. Back towards that knee. Still keeping myself fairly well supported. Just switch back and forth between lunge position. Do a little bit of compression broadening. Actually, that wasn't really compression broadening. This would be a little bit more compression broadening. Just to spread some of those adductor fibers out. So they're all pretty much, grouped in together, a little bit overlapping each other. Stands to reason that they get stuck into with each other pretty good. Bring my client's knee into a flexed position. And I can do a little bit of pin and stretch. So I have an area pinned down. This particular area, just on the lateral side here. You use nice broad surface. Sorry about that. Nice broad surface, or if I feel a really solid adhesion, say I want to get bicep femoris down here a little bit more, and pin down. Basically, as I take it through the motion, I'll be waiting to see if I feel any type of resistance. That'll tell me that I'm in the stretch, and that'll tell me that's where I need to pin and stretch it a little bit more. So you saw I went through the first 80% of knee extension pretty quickly, but within that 20% there, that's when I found the stretch. So that's where I'm holding it. If you're not a fan of using your thumbs, and most people aren't, because it's not a good habit to get into as a massage therapist, broadside of your forearm, broadside of your palm, loose fist, stacked fingers, whatever you need to do in order to be able to hit that technique. If I want it to be a little bit mean, I can get my client to do this for me. So let's say I'm gonna pin right in about here. So that's another good adhesion spot. I'll just get you to slowly extend your leg while I pin this down. I'm gonna let go. I'll stack my hands up. My client is doing it for me. Okay, bring your knee back up. I'm gonna release as she's bringing it back up. I'm gonna reposition and I'm gonna reapply. It was a little bit harder to hold because that muscle's firing underneath my hands, but you have to really take advantage of that muscle, or the muscle firing, in order to get the most of the effect out of this technique. So we'll do a little bit more petrissage just within this area, because again, I feel quite a bit of adhesion work up here, but it feels fairly superficial. You might even be able to see it on the recording. Just flush the area out. Redrape my client's leg. So again, just making sure that we're nice and supported underneath the knee. If they have ligament or meniscus injury, knee replacement, whatever the case may be, not supporting that knee is going to be excruciating for them. Just as a side note, there's a good chance a fair amount of you have been taught by a well-intended second-year student how to do some pin and stretch on the piriformis muscle. I will tell you that if your client has compromised, if the structure of their knee, the support structures within their knee have been compromised, let's say meniscal ligamentous injury, doing a technique like this is going to be excruciating. Any amount of movement using rotation of the hip with the knee in this levered position is likely going to be excruciating. So be careful with that. While I'm here, I might as well do a little bit of glute work. Yeah, I know this isn't going to be covered till Module 8, but heck, we're here. Just want to be mindful that exiting from about, what is it, L4, about S3, we're going to have the sciatic nerve roots going into the sciatic nerve. So it's going to come in between or pierce through, go over underneath the piriformis muscle. And it's going to go sort of in between the greater trochanter ischial tuberosity. So think about this area here. You're going to have a nerve about that thick, maybe thicker. You want to be careful. At least approach it with a little bit of caution. I rarely go directly up and down. What I'll often do is sort of come in from the side. Now, by addressing the glute, really solid treatment for the IT band. Just using big palm surface here. I'm compressing, holding, waiting to feel what the muscle does in response to me. I had a student ask me a question in my last in-person class when they were talking about, what are some techniques that I can use? What are different techniques that I can use within the glutes? And my answer was that there's not so many techniques necessarily to be used, but rather approaches, angles to the glutes, and the structures that lie beneath the glutes. But even just with that unfortunate picture that I drew in class the other day, a couple weeks ago, here's a little bit of a demonstration for it. So what I'm going to do is I'm going to do a 3-point muscle approximation on the glute max. Credit's going to Diana here in Edmonton for showing a bunch of students this, which then made its way to me. So I'm going to show it to you. So I know we're kind of using like palm of the hand on a client's butt. Might feel a little bit weird, but the intent behind it is really important, and also explaining to what your client is, or what you plan on doing with your client. Obviously, I've worked with my client numerous times over the past 6 years, so she has an idea of exactly what I'm doing. But you can basically just state that with the glute max being a large muscle coming in towards your IT band here, what we're going to try to do, because oftentimes the glute max falls into inactivity, or it falls, it just ends up getting weak and inhibited due to the phasic muscle fibers. What we're going to do is we're just going to hold the origin, and we're going to bring the origin and the insertion in closer to each other. So we're going to focus this direction first, bringing them in together. Let's just pretend that we held that for about 30, 45 seconds, maybe longer if need be. Then we'll reposition, coming in this way. And then finally, in this way. If you're thinking this and you're raising your hand and you're like, no, I don't want to touch my client's butt, not like that anyways, here's another approach to it. On their border, or loose fist, come up like so. Takes away the hand on the sacrum. It's easy ergonomically to do. I'm just in a good lunge position. A gray shirt, gray pants, gray Crocs, gray socks. Everything is gray. How you doing on the table? She's good, everybody's good. Cool thing about this technique too is you can quickly change your intent from an approximation to a compression. So I'm getting up at the upper fibers and I'm actually feeling a bit of a spasm as I'm stretching the muscle fibers out from the insertion to about midway to the muscle belly. So what I can do here is, rather than bring it closer this way, which when you're feeling a spasm or you're feeling kind of like a jumping feeling, that's usually an indication that the muscle approximation is working. But let's say instead I wanted to change my approach. Basically I would just go from, change my setup, from going to the approximating towards the sacrum, just sort of resetting, and coming back down a little bit more, so I'm sort of going not directly downwards, but more closer to going downwards. I often find when I'm working in these areas, the upper glute fibers tends to be the ones that aren't as tight. Okay. A little bit of rocking and shaking, see the improvement that we had. So we definitely felt a lot of movement within the distal portion of the knee while we were doing this, but not too much in the upper portion of the knee. Whereas as we're moving it now, oh heck yeah, we can even see there's some decent movement within the lower back. Off to a good start. So beneficial treatments here in order to get into that popliteus a little bit here. Let's actually cover that. I can get a little bit of stripping from this angle here, so I'm just using my thumbs and just going from origin to insertion. Sort of stripping across. Does it feel okay? Mm-hmm. Does it feel good? Yeah. Sometimes I forget, like, does that hurt? No, not so much. Okay, cool. Does it feel good? I don't know. So yeah, sort of stripping along, nice and slow. Shout out to Kim, this is her favorite spot to treat. Okay. And we'll just do a quick lazy effleurage. So yeah, what we did here, certainly beneficial for muscular imbalances, especially for somebody who's sitting for a prolonged period of time. Adductor strains, hamstring strains, especially as we get towards the subacute chronic stages. The big difference is there is you want to take some time to sort of modify how much pressure you're using. Because obviously we talked last class about the removal of the protective spasm. So if it's within the early subacute stage, I would use probably, let's say, 30-45% of the amount of available pressure that I'd have, increasing it by about 10 to 20% as it gets towards the late subacute stage, increasing it to probably about 80, anywhere between 70 to 100% of the available strength that I would either have or that I would typically use on a client. Right now we're just doing a little bit of a stretch along the entire posterior fascia here. So rather than a cross hand, I'm just sort of locking my shoulder blades into a retracted position and just allowing my shoulders to push either direction. Does that feel okay? Mm-hmm. She's okay with it. So yeah, we got good for muscular imbalances, good for hamstring or adductor strain, good if there's some arthritic changes within the knee affecting the popliteus, as well as some cross fiber and some myofascial just for good